reassuring the patient is the first task, because if you cannot reassure the patient, they will continue having headaches because they're worried. So investigate fears. They need to take responsibility for doing this. You will not be able to fix their headache for them. You can only help them. So you win them over as a partner. Trigger identification and control. I have a sheet of dietary triggers that I give my patients to look for. You can do exclusion diets, and I don't know. I mean, some people say it doesn't do anything. I've had pretty good luck with it, and it also is a very holistic, natural approach, which often throwing medications at these already sensitive people can really backfire because they need very small doses. They're sensitive to everything, including medications, including side effects. So that's why you get away with 10 milligrams of nortriptyline in these people. So I do talk about herbal treatments. So there's things like feverfew or butterbur or magnesium. Butterbur has some concerns about liver toxicity, but these things have been studied in randomized controlled trials, and they do have some benefit. I do, stress reduction, meditation, exercise, all of that stuff is good. Sleep hygiene. It's kind of a whole package deal. Abortive medications are important. You do want to counsel about rebound headache, of course. And so I tell my patients, don't take any one drug on more than 2 days a week. Doesn't matter how much you take in a day, as long as you stay within the maximum dose. It's not the amount per day or the amount per dose, it's the number of days per week. So anything more than 3 days gets you into trouble. So I tell them, stick to 2 days and then swap drug, if you must. And people say that paracetamol doesn't cause it. I've seen paracetamol cause rebound headache. I've seen aspirin cause rebound headache. And so what I do with patients with rebound headache is I tell them the headache will get worse before it gets better. I put them on naproxen, 500 milligrams Q12 for 2 weeks. Make sure they don't have any stomach problems. If they do, I might add some omeprazole, and then I usually put them on a tricyclic, like 10 milligrams of nortriptyline or 10 milligrams of amitriptyline if they have a lot of sleep problems. And then I do that for a month, and then if I had the luxury of seeing them back in the public sector, I'd then see them back and see how they go, and then stop, slowly wean. Obviously the naproxen is gone, and wean the the preventive. I treat with a preventive in that setting for as long as they've had the headache. That's my kind of rule of thumb. So if they've had a daily headache for a month, I'll start tapering after a month. If it's been 6 months, I'll start tapering after 6 months. And then you have to assess whether they need chronic prevention after you taper them. This is just when you want to start. So that's our biggest sort of gripe, I guess, when we get referrals from primary care, is that people haven't tried preventatives. We really, and I don't know, you're all from all over the country. In Wellington, we cannot see people in the public sector unless they've tried at least 2 preventive medications. We'd like people to use the 3D health pathway. Those pathways should be everywhere. And if you can follow that, we just don't have the capacity to see these people. And it saves us a lot of time if you try those things that are on the pathway before you contact us, because every time we have to write back, it's just one less bit of time we have for somebody else. Psychological counseling isn't that helpful, but sometimes it can be when there's a lot of anxiety identified. There is comorbidity with anxiety and depression. I said downplay that before and but be aware that there could be a component. And then you can also do things like biofeedback, which has pretty good evidence base. So these are relaxation therapy that it does work. And it's not because they're stressed and that's why they have the headache, but you can actually learn to control the headache feedback loop by reducing brain activity, which meditation can achieve. So meditation can really help with this. Now, just quickly, there's a few new things out on the market you maybe have heard about, like the calcitonin gene-related peptide, and then antagonists to that and monoclonal antibodies to that. They're not available yet in New Zealand. They're very expensive, and there's a lot of discussion internationally whether that's something that should be used. It probably will be available in New Zealand and probably funded, but a very small group of people. It's sort of $7,000 a year, I think. and it's really for refractory patients. But the idea is that it's a both that can be used as preventative or abortive drugs, and it's a monthly infusion or once every few months infusion that keeps the headaches away and actually modulates the nerve tissue a little bit. That some people have heralded as saying that this could be a cure, but this is pretty early days still, and it hasn't made it into our routine practice, and hardly anyone where is it sort of a standard of care. So 49-year-old man with weakness. What would you like to know? The weakness is in the feet. It started about a week or two ago, maybe about 7-8 days, something like that.
Any numbness or tingling?
Yep, there's some numbness in the feet as well.
Are you diabetic?
No, I'm not.
What's your alcohol intake?
1 drink a day, red wine, from my heart. How big is my drink? About this big. Red wine, 1 glass.
How does the weakness affect you?
Well, I'm starting to drag my feet, and I'm really worried about it. I'm dragging my feet. The question was, how does the weakness affect me? I'm dragging my feet, and I'm mostly just quite worried about why my feet. Yep, both feet.
So definitely no numbness anywhere else.
Nope. No weakness anywhere else.
Any change in vision?
No change in vision.
Blur.
No blurred vision.
Any back pain?
Maybe a little bit of back pain, but mostly I have some limb pain. My legs hurt.
Trauma?
No trauma.
Fever?
Well, I've had a flu a few weeks ago, maybe 3-4 weeks ago, but other than that, now I'm fine.
This is getting worse. Has it changed?
Yep, it's getting worse, and that's why I'm here. I'm really worried. What are you going to do about it? Just kidding. Huh?
Are you seeing?
Yeah, well, what do you mean, like, is it moving up my legs? It seems to be, like, the weakness is staying in the feet, but it seems like my numbness might be going up to the knees now.
Any trouble swallowing?
No trouble breathing, no trouble swallowing. So let's just stop here. So, could it be a muscle problem? No, because numbness. Could it be a neuromuscular junction problem? No. Could it be a peripheral nerve problem? Yes. Could it be a plexus problem? It's possible. You could have bilateral pelvic plexus problem, but it's pretty unlikely, and also it'd be pretty weird to just get the feet involved. But that's. What about a nerve root problem? Bilateral lumbar nerve roots. Yeah, could be. He does have a little bit of back pain. What about a spinal cord problem? Could be. You're going to do more on examination for that? Yes. What about a brainstem problem? Not likely, because no cranial nerves involved, and also bilateral. You have bilateral symptoms that only affect the feet. It would be a pretty hard thing to do with a brainstem lesion. And what about a cerebellar or basal ganglia?
No.
2 things. One, you've got numbness and it's bilateral, and it'd be pretty odd to get that. Sensory, yep. What about a brain problem? Like a cerebrum or white matter? What's atypical? Bilateral, right? So in order for you to get bilateral symptoms, you really would have to have bilateral brain lesions, and now you're talking about 2 lesions, and you're always trying to fit it all into 1 lesion. So it's possible that maybe he had 1 really odd stroke affecting 1 foot, and then 1 really other odd stroke affecting the other foot, but that is pretty unlikely. Also, he's getting worse over some time. Or, yeah, okay. So, sorry?
Is it inflammatory?
Why do you say that?
I'm thinking about polio, actually.
Now, polio is an interesting one. Why is this not polio?
Because of the numbness.
Because of the numbness, right? So polio affects the anterior horn cells, which is a motor.
It's a progressive thing, which is
It's-
everything of inflammatory.
Yep. So the course is consistent with inflammation. But let's just move back to, before we do our syndromic allocation, back to our localization. So we've narrowed it down to what? Peripheral nerve or nerve root, pretty much, right? Spinal cord maybe, but wasn't as typical for that. So when you do your examination, what are you going to do now? You're going to check reflexes to confirm that it's a lower motor neuron problem. And this person has no reflexes in the lower limbs, but decent reflexes in the upper limbs. Better reflexes proximal than distal. And so what does that tell you? That it is a lower motor neuron problem. You've kind of dismissed your spinal cord, and so now your nerve root or peripheral nerve area. Okay. Now you've diagnosed it to that part of the nervous system. Now you're looking at your duration and your course of things, gradually progressive over a couple of weeks, which puts you into that inflammatory time frame. So some kind of acute, subacute inflammatory condition. And what other key historical fact did we uncover? Had a flu. So what are you thinking at this time? You're thinking Guillain-Barré. Okay, and then you do your examination, you have some weakness and some numbness, absent reflexes, and you feel really confident about picking up the phone and calling us and sending the patient to ED. Right? Okay, so neuropathies in general. So the things to think about are toxins, and you rightly asked about alcohol. Now, alcoholic neuropathy wouldn't generally develop over just a couple of weeks, and that's usually painful because it's a small fiber neuropathy. Heavy metals, chemotherapy is a really common thing we see, and then glucose is probably the most common problem. Now, on the glucose front, when you check for this, you can do a random glucose, but ideally you want to do a fasting glucose or even a glucose tolerance test. Now, hemoglobin A1C is really good at telling you what the sort of glucose status has been over the previous 3 months, and that's a great screening test. But if it's normal, you're really concerned about a small fiber neuropathy in somebody who definitely isn't drinking and has no other conditions I'll talk about in a second, you may want to consider a glucose tolerance test, because it may be that they have glucose intolerance that drives their glucose up intermittently, not enough to really make them diabetic, but enough to damage their nerves when that happens. And sometimes you can treat that and prevent the neuropathy from getting worse and prevent diabetes before it happens. There's a number of inflammatory conditions, including the GBS and then a few other ones that can cause neuropathies. Those you'll see less commonly, but it's certainly something worth checking for. There are some infectious causes that are even more rare, but HIV does occur occasionally, and probably in our population more Hep C, so be aware of that, and you want to think about those things. From a genetic perspective, Charcot-Marie-Tooth disease is a funny little entity in that it can go undiagnosed for years, and then you do nerve conduction studies and they're blatantly abnormal, and the patient's only just presented with symptoms. So they're the ones who have the high arch foot and the hammer toes, and so they have foot deformities that have developed over time. And you can ask the patient during the examination, do you ever have trouble buying shoes? So these people notoriously find it difficult to find good fitting shoes, and they obviously have generally a strong family history, although sometimes it can occur sporadically. Paraneoplastic conditions, something to think about, and I won't go into too much detail there. Now, you do want to think about multiple myeloma and amyloidosis. So I'll check, next slide has the tests you want to do, but you want to look at things like serum protein electrophoresis and free light chain assay. So amyloidosis is the other one that causes small fiber neuropathy. So amyloidosis, alcohol, and diabetes are sort of the hallmarks that you want to, the three that you want to think about in somebody with small fiber neuropathy. Some vitamin deficiencies can cause neuropathy other than B12 and folate. So those everyone always checks, but there are a few other ones. And then when you do your initial check, you do want to check for some general metabolic problems. So here are the blood tests you want to do. Doing the history, you want to get idea of the fiber type. So is it large fiber, which causes the numbness, or is it small fiber, which causes the pain? Is it causing motor problems not, and you can then narrow it down, but that's probably a little bit more than you really want to be doing in your surgery. So if you start with these blood tests and just get your first screen out of the way, and then if that's all normal, you can either refer them to us or you can go to the second level. Now, anti-GM1 causes a motor neuropathy and anti-MAG a sensory neuropathy. These are expensive tests along with the paraneoplastic studies, and I would say if you've exhausted these sort of more routine tests, it's probably time to send them to us. And we're talking about people who have disability from this, more than just a little bit of a tingle in their feet.
Sorry, I don't know SPEP or
Oh, sorry. So SPEP is serum protein electrophoresis and free light chain assay.
Okay.
Apologies, thanks for asking. So that's your Benz-Jones proteins.
Why do you check lipids?
Because hypercholesterolemia can cause neuropathy, as can triglycerinemia. So getting that under control can improve. Now the problem is statins can also cause neuropathy, so but not very commonly. So when we get to this stage and we have somebody like this chap we had with the Guillain-Barré, or we're suspecting something like CIDP, which is the chronic version of Guillain-Barré, which is not a monophasic illness, we then will do an LP. So LPs are really useful in that setting and really the diagnostic test for an autoimmune subacute or chronic neuropathy, because we see elevated protein and generally normal white blood cell count. And if all else fails, you do a muscle or nerve biopsy. Usually we do them together to look for the abnormal muscle. If the nerve is damaged, we can see changes, denervation in the muscle on the muscle biopsy that can be very useful. We also do, and we have nerve conduction study and EMG. Nerve conduction study is obviously looking at the nerves, but the EMG, which is the muscle test, is a really useful test to do because it can tell us whether the nerves have been functioning or not, because the muscle we can tell from the muscle if they've been denervated, if the nerves aren't attached to the muscle, because we see changes in the muscle. And that's what a nerve conduction study looks like. I don't know if you've ever seen it. So we put would be an ulnar neuropathy test where we put electrodes on the hand, stimulate at the elbow. So we send a shock wave down there, record it, and we see an amplitude and a latency. So we measure it. This is where the stimulus comes, and then we measure the delay to the electrode. So we can tell demyelinating if it's delayed or slowed velocity, and axonal if the amplitude drops. So if that is proximal and that's distal, if that's half the amplitude of the other one, we know there's something wrong with the axon, and that helps us narrow it down. And electromyography is where we stick a needle into the muscle and make recordings, and it's actually a lot of it is by sound. We listen to the motor unit potentials on the muscle, and it has characteristic sounds. If they're really deep sounding, it's more a denervating pattern. If they're really high pitched, it's more of a myopathic pattern for inflammation. So that's what we do during that test. So actually I do have 2 more cases from this morning that we'll just go through a little bit more quickly, and then we'll go to the next session. So this is a 60-year-old woman with weakness, and I'll just tell you a little bit about her rather than asking questions. So she's had 6-month history of progressive left upper limb weakness, and recently has noted some problems in the right upper limb. She's also had some problems with coughing a few times and choking on food, some emotional lability, and she's noticed some twitching. So with that story, let's just quickly run through our localization. Do we think it could be a muscle problem? So it could be some muscle problem, right? There's some motor, primarily motor symptoms. There's no sensation issues. Could it be a neuromuscular junction problem? It could be. Twitching isn't particularly typical, but it's a fairly non-specific sign, and you wouldn't want to discount that entirely. What about a peripheral nerve problem? The choking and the coughing. Could the peripheral nerves that help you cough, like the phrenic nerve. The diaphragm is innervated peripherally as well. So it is, even cranial nerves have a peripheral nerve component. So you can get peripheral neuropathy, like Guillain-Barré, for example, is a nerve problem that can affect bulbar muscles. So it could be a peripheral nerve problem. It would be pure motor neuropathy, which are a little bit less common than mixed neuropathies, but it's conceivable. What about a plexus problem? So that's the one it cannot be, because the cranial nerves do not run through plexi, and the same with nerve roots, right? Technically, the spinal nerve roots, although again, maybe you could get some bulbar symptoms, some radiculopathies, but technically speaking, if you're talking about spinal nerve roots, no, should not have bulbar symptoms. And what about a brainstem problem? So anatomically, just from a distribution perspective, it's not completely impossible. You have bulbar symptoms, but you have this bilateral situation that's only involving motor. The brainstem's pretty small space, and you'd expect some sensory and some other symptoms, but it is possible. So you could get cortical spinal tract involvement and cortical bulbar tract involvement just at the level of the brainstem. But if you're going a bit further up, like cerebellar, basal ganglia, or the rest of the brain, you wouldn't be expecting it to be bilateral, right? So you're looking at a bulbar kind of a brainstemmy thing. We didn't talk about spinal cord. Couldn't be really spinal cord because you have the bulbar involvement. So you're talking brainstem or peripheral nerve, maybe odd sort of nerve root sort of thing, but or muscle, neuromuscular junction. Yeah. So most of what you're thinking about is in the peripheral nervous system, and then maybe something in the brainstem. So you're going to examine this person, and you're going to want to look. First, you want to just make sure there is no numbness to confirm that. So the patient does not have numbness. She does just have weakness. And then you want to look for upper versus lower motor neuron signs, because you want to exclude the central problem versus a peripheral problem. And so you examine her, and she is hyperreflexic everywhere. She's got Babinski's bilaterally and brisk reflexes in her upper and lower limbs. So now you're thinking, okay, well, that looks a little bit more central. And then you're looking at her limb and you see twitching. You see muscle twitching. What does that make you think? What is that, an upper or lower motor neuron problem? 50-50. So twitching, there's different kinds of twitching, right? There's twitching like a seizure kind of twitching. We call that more of a jerking movement, although it's a bit arbitrary. So by twitching, I mean you look at your arm and you just see a fasciculation. So you're looking and you see a fasciculation. Is that an upper or lower motor neuron problem? It's a lower motor neuron problem, right? So what you have is the muscle is not innervated properly by a nerve, so it just kind of does its own thing. So the nerves also suppress muscle activity, and if there's denervation, you get fasciculations, and that's a peripheral problem. So now you have hyperreflexia and fasciculations, an upper and a lower motor neuron problem. So what does that mean? Does that make any sense at all? Can you think of a situation where that could happen? So you're saying MND or motor neuron disease, and where does MND live? It lives in the anterior horn cell, which is right at that junction between upper and lower motor neuron. So you're getting a bit of retrograde cortical spinal tract involvement in the spinal cord, and anterograde some at the junction of the anterior horn cell, you get that lower motor neuron. So you get that junction, it does at some point have to go from one to the other, and if you have that involvement, you get both. So this person has motor neuron disease, and you've got a neurodegenerative process that's been taking months, gradual evolution, bilateral, motor only with upper and lower motor neuron signs, and the emotional lability is a bit of a central nervous system involvement that you get with this because it does involve a bit of the brain as well. So it's a fairly widespread problem, but only affecting the motor tracts. So you should not get numbness. So you have upper and lower motor neuron signs. When you need an EMG to make this diagnosis, there's no blood test and no imaging that can give you that diagnosis. So you need to do a needle examination, and you're looking for denervation. Denervation physically looks like fasciculation, but we look for something else called fibrillation, which are fasciculations just really tiny. And we can see them only electrographically, and we want to see them in at least 2 or 3 body segments. So we want to see it ideally in the arm, somewhere in the arm, the leg, and the paraspinal muscles in the thoracic cord or bulbar muscle. So we've got 4 segments. We've got cranial, cervical, thoracic, and lumbar. And we want to see ideally denervation in 3 segments to make that diagnosis. When you do nerve conduction studies, you can see low amplitude, which suggests an axonal motor neuron component, and that's that peripheral aspect of the disease, not a demyelinating problem. And you see completely normal sensory nerves. Now, these people can be older, they can have diabetes and sensory problems as well, and so it can be tricky, but the disease itself only causes motor problems. Now, CPK is a really good test, the one blood test that is actually useful in this, and you can do a CPK, and if it's slightly elevated, sort of in the 300s, that gives you a suggestion of motor neuron disease. There's a differential diagnosis, which is the cervical spine disc disease, because that gives you both upper and lower motor neuron symptoms and signs, because you're getting the nerve root and the spinal cord. That's the other place where you get a junctional problem between the 2 parts of the nervous system. That's the most common differential. Motor neuropathy we talked about, so we have excluded that in this patient because she has upper motor neuron signs. Right, so we've already clinically excluded that, and then we can do a bit further on EMG with that. Spinocerebellar atrophy is just a type of central nervous system problem that has only the upper motor neuron signs, so you can exclude that if they're lower motor neuron signs. And then there's subgroups of others. We're talking about here ALS, but there's other forms of motor neuron disease like Kennedy's disease, which are just a little bit different, spinomuscular atrophy. So there's some other conditions that are more rare, but that's the main thing you want to think about. And care is primarily supportive, and we do occasionally prescribe riluzole, which prolongs longevity but not necessarily quality of life. So I just thought I'd mention that. That's one of the more common disorders that we see that aren't your neuropathy and your headache and epilepsy.